Okay, so good evening. I'm Randy Kearns. I'm your professor for HCM 2000, and tonight we'll be going over public health preparedness and medical disaster management, particularly as it relates to the healthcare sector. And so key terms, there's quite a few key terms, but I do want to be sure and focus on a couple of things that we will see both tonight and some of it will spill over into next week when the topic next week is emerging infectious disease. I did include a more extended presentation for next week. Obviously, if you've taken a look at it, you'll see that it's fairly extensive. That's something that I've used before for the State Department. It's actually a course that I teach for the State Department. The last time that I used that was last year in Turkey. And while emerging infectious disease has far more implications than just what we're going to be dealing with in the healthcare management world, really the first chapter of it, or the first section of it, deals with key and critical components of emerging infectious disease, some of which, some of those terms, obviously I'll go over tonight to help tie that in. So again, if we look at our key terms, I've got HVA and THIRA. HVA is the hazards and vulnerability analysis. If you work in healthcare and you work around people who are involved in disaster management or disaster operations in the hospital, one of the things that they will do in the healthcare world is called an HVA. It's a hazards and vulnerability analysis. Over time, a somewhat similar approach called threat and hazard identification and risk assessment, also known as THIRA, is what's more likely done in the government sector. And actually, if we go back several years, I didn't include it, but it just reminds you how things continue to change. About 30 years ago, we called it a HCM, Hazard Identification and Capabilities Assessment Multi-Year Development Plan. Anyway, all of that gets back to the point of we need to identify our hazards because we can't control our hazards. Within the next 24 hours, still another hurricane may impact a part of Louisiana. We can't control that. Those are hazards. Our vulnerabilities we can control. How vulnerable are we to the hazard? And so when we do an HVA, that's really a gap analysis. It's looking at the hazard and then looking at our vulnerabilities to the hazard and then analyzing what the difference is. What's the gap between, the potential threat and then how do we manage that? Again, if you work in the disaster world that's more related to government operations, it's more likely to be referred to as THIRA. And again, it's a pretty similar process. It is slightly different. If you're receiving FEMA dollars, and most counties, cities, and states do receive some type of disaster planning funding, then they're more likely using the THIRA process. But if you hear the two terms, just understand that they're basically the same thing. One's a little bit more simplistic approach. With threats and hazards identification and risk assessment, a part of threats is also not just look at hazards. Tend to look more at natural disaster. Threats tend to look more at man-made disaster, as well as the hazards associated with natural disaster. But again, both of them are basically the same thing, just one's more likely to be found in the hospital healthcare world. The other one's more likely to be found in the government world. And then all of this informs something called an all hazards plan. And the whole premise behind an all hazards plan is there's a lot of things that we do in the disaster planning process that's very similar, whether it's dealing with a tornado or dealing with a hurricane, um, flooding, wildfire. A lot of those disaster planning scenarios still include a lot of the same planning processes. And so a number of years ago, about 35 years ago, we started taking our disaster plans and melding them into one large base plan, our base operation plan, and that's referred to as all hazards planning. And then we had unique components for unique situations. If you were in Iowa, as an example, you probably didn't focus on hurricanes, but you probably did focus on tornadoes. If you were in California, you probably didn't focus on hurricanes, but you focused on wildfire and earthquakes. But key components of the all hazards plan in California looks very similar to key components of the all hazards plan in Louisiana or North Carolina, or pick your other state. Anyway, and then something that's certainly been an issue and currently is an issue in a number of states in the U.S. right now, and that is surge. And what I mean by surge is a term that we use when we have more patients than we have space to put them in or people to take care of them. And so we look for ways that we can build on our surge capacity or expand on surge capacity or do what's called surge planning. And again, when we talk about surge right now with COVID-19 as an example, although we're not in particularly desperate shape right now in Louisiana, there are a number of states that are. And where that really creates risk both for the patients with COVID-19 as well as other patients is cross-contamination. They can become infected. And as we discussed before, if you went to the hospital with a heart attack, you don't need to wind up being treated for an infectious disease at the same time that you contracted most likely while you were at the hospital. So surge planning is designed to help absorb additional numbers of patients without putting additional patients at risk. But we know that when there's a surge of patients, it slows down things. It makes it more challenging for us to care for other patients that aren't the primary reason we're having the surge at the moment. And an example would be if we look at unusual death patterns in Orleans and Jefferson Parish in March, April, and May, we'll see that and we do see that more people died outside of the hospital of natural conditions associated with stroke and heart attack than we would normally see. And the reason for that, we believe, is because people were afraid to go to the hospital. The hospitals were in many cases overrun by COVID patients. And in many cases, it was all some of the hospitals could do to manage the surge of patients they were dealing with that had COVID. And that's not unusual. It's in fact, it's common, and that's why we do surge planning for all of the hospitals around the country. For some, it's easier than others. Actually, in Louisiana, particularly New Orleans, surge planning is a little bit easier in New Orleans than it is in some places. Let me give you an example. After Hurricane Katrina, more than half of the people that lived in the immediate area evacuated. And only about half to 2/3 of that half that evacuated have come back. And what that's left is it's left, in some cases, a lot of empty houses. It's left a lot of businesses that didn't start back up. It's also left a lot of empty hospital space. And so as the disaster, as COVID-19 kicked into high gear and suddenly we had this large surge of patients, we actually had some space in some of these hospital buildings to build out additional ICU beds. Ochsner Health at Jefferson Highway added some additional beds. LCMC at University Medical Center added some additional beds because they had built that hospital in a way that they could add some additional beds. And so there was additional space there, quite frankly, that's unusual. Most large cities that are growing rapidly, such as Miami, particularly Charlotte or Atlanta, those cities have in many cases, their hospitals have already maxed out the space that they have. They're looking at how they can expand their space. And anytime, even Atlanta, there's a hospital there called Grady, which is one of the largest hospitals in the country. Grady routinely runs out of space on a regular basis. And so during the surge of COVID patients, they had already set up a number of tents to be able to manage and absorb patients. But again, if you go to the hospital, you're not really expecting to be cared for in a tent. Just understand that is a temporary space that we use at times in our surge planning. And so these next terms, I've got a slide for these, but it helps us understand. So in the most common way that we teach emergency management is there are 4 phases of emergency management. There's the planning phase, also known as the preparedness phase, but the planning, the response, the recovery, and the mitigation. In certain circles, there's a 5th phase or a 5th component, and that's called prevention. Again, depending on the literature that you read, you'll either read prevention, planning, response, recovery, mitigation, or you'll read just the 4 planning, response, recovery, mitigation. And we do sort out recovery into 2 different pieces, short-term and long-term. I've got a slide for that later. I'll show you just briefly what that means. And then mitigation. Mitigation is a phase that really starts to come into play after the disaster ends and before the next disaster begins. And one of the key parts of mitigation is to look for ways to avoid the disaster. Although it's been 20 years now, I worked in hospital administration when Y2K came about. And about 1995, 1996, computer programmers identified substantial numbers of vulnerabilities in so much computer architecture where codes had been written and written quickly to not include a 4-digit code. So, for 1993, the coding included 93, but didn't include 1993. And so that worked fine for 89, 90, 91, 92, 93, 94, 95. You get the picture. You get to 99, it didn't work fine to make that conversion to 00. In some cases, the computer thought that was changing the date back to the year 1900 instead of the year 2000. And so what was recognized in the mid-1990s was there was this enormous vulnerability of so many computer systems, defibrillators, so many electronics that were written, again, with what's called short coding. And so a mitigation strategy was, we spent 3 years replacing that equipment, rewriting really millions of lines of computer code. And then by the time Y2K came about, by the time it was midnight on December 31st of 1999, and we flipped over to the year 2000, suddenly all of the things that some people had forecasted would be the end of technology as we know it didn't happen. Almost to the point that people said, see, we told you there was nothing to be afraid of. Well, we spent 3 years, 4 years really, working on changing code, buying equipment, replacing equipment. That's what mitigation is. It's identifying the disaster before it occurs and taking all the steps necessary to try and avoid it. And, you know, wearing a mask today, as an example, is mitigation. It's a good mitigation strategy. Early on, actually, if you took my disaster operations class in January, of this year, I was telling students what type of mask that they probably need to go ahead and buy and have some put aside. Actually, the first mask that I bought for my family was the first week of February. And the reason was it's a communicable disease. I know what that is. I know what the mitigation strategies are. And I knew if we were going to be in for a long-term impact, you know, I don't know how long this is going to go on. I mean, realistically, there's a real opportunity to end much of this in the next 6 to 8 months with a good vaccine plan and continued improvement in our treatment mechanisms. But we're not there yet. We're a long way from there. And that's why we use mitigation strategies. When we talk about social distancing, that's a mitigation strategy. When we talk about everyone wearing a mask, that's a mitigation strategy. And the whole point to that is it won't stop you from getting sick, but it will minimize the opportunities you may have to get sick. You know, I wear a seatbelt when I drive my car. That's a mitigation strategy. I don't drive 100 miles an hour. I drive a little bit more sensibly. That's a mitigation strategy. What are things that you do to avoid incidents or accidents? That's what mitigation is. Plans in the planning process, really important. Plans are really the documents, but the planning process is really that key piece. It's where people are involved in developing the plan. Resources are the things that you own or the things that are available to you. You know, what type of resources do you have? And working in a hospital, one of the key resources each hospital has to have multiple generators to maintain at least core operation of the facility if power has been cut to the facility. The University Medical Center, as an example, has an entire building full of large generators. If you are entering from, trying to think of the name of that street, if you're driving away from Interstate 10 and University Medical Center is on your right, really the building right before you get to the parking deck is a very large building filled with something called potable water, which is water that can be used for lots of different activities, safe activities. It's safe. And a large number of generators and a substantial amount of diesel fuel to keep those generators operating for up to 9 days to operate the entire University Medical Center. So again, all of those in terms of resources, those are resources to maintain the functionality of the facility. Just understand if you work at a hospital during a disaster, you're typically the place people are going to search out for help. You're typically the place where people are going to come to, you know, to get their needs met, and part of that includes the resources that you'll have. One key component of any disaster planning process is called a gap analysis. Earlier when I talked about the HVA, the hazards and vulnerability analysis. So the difference between the hazard and your vulnerability to the hazard, it may be a gap. There may be some gap there of what do you have versus what you need. You know, I hope by now, you know, this is the 7th named storm that may impact the greater Louisiana area, some part of the state. I hope you've had a chance in the last several hours to go out and fill up your gas tank in your car. I doubt you're going to need to evacuate because of this, But a part of the gap analysis is what do I have versus what do I need, and then what are the steps that I'm taking to fill that gap. Response, let me skip response. There's a couple of these I want to skip because I want to show you what it looks like in the slide so that you have a better understanding of it. Responder safety, and both from a restore order standpoint and an environmental concern standpoint. So if you are involved in the response, one of the important things that we look to is how do we maintain the safety of our responders. Again, you know, at the time you responded, at the time you went to work, you were healthy and I guess happy, but you certainly weren't injured and you weren't sick. And certainly it's important for us to create a safe environment of care. And that includes being sure that people have the personal protective equipment, we call that PPE. People have the things they need to protect themselves and to be safe and to stay safe. Endemic, outbreak, epidemic, and pandemic. So those four words we use to describe different types of disease outbreaks. When something is said to be endemic, that means it's fairly well saturated in a local community. And you know, as an example, when we get into high gear of flu season and it's saturated the local community, we refer to the flu being endemic. And we hope people have taken a flu shot to try and mitigate the effects of the flu, because of how the flu vaccine is developed. Each year, the CDC and the World Health Organization get together their best scientists and they try to forecast what type of flu they will see in the fall, because it takes 3 to 5 months to grow out the type of and to build out the type of vaccine that they need, the amount of vaccine that they will need. And so they do a lot of computer modeling and simulation. But as an example, the flu vaccine that I received, I guess it's been about 2 months ago now, includes vaccine for H1N1, that's a type of the influenza, H3N2, it's another type of influenza, and influenza B. Again, it won't keep me completely protected. I won't be completely immune to all influenza, but if I do get sick, it should reduce the effects of the illness. But again, influenza is endemic to us. It occurs on a regular basis. At some point, there's some belief that COVID may be that way too. And that's okay as long as we have a vaccine for it. Just understand COVID has killed more Americans in the first 7 months that it's existed in the United States than the influenza has in the last 5 years on a 5-year total basis. So it's not the flu. It's incredibly dangerous. It's far more dangerous than anything that we've seen on the planet in the last 50 years in terms of a novel virus. And so that's a part of the concern for it. But endemic to outbreak. So when this first emerged in Wuhan, China, and Wuhan appears to be the epicenter where the first cases were seen, that's where that was considered an outbreak. It was seen in a lot of different areas in that city, and so it was fairly widespread in that city, and so that was where the outbreak occurred. As it began to spread across other parts of China, and China, because you know there are a lot of reasons why I would not want to live in a communist nation. But one advantage that China has, and any communist nation has, is they have a lot of absolute control over their population, and and they can order people to stay in certain areas, and people have a tendency to stay in certain areas because the implications of not doing that can be pretty catastrophic in a communist nation. And so they were able to at least manage a part of their epidemic. But it did get out, and it did get out to other parts of the world. The world is a very small place today. There's not a lot of diseases that don't wind up in starting in one part of the world and winding up around in a transcontinental way at some point in the next several months to the next several years. We saw that with AIDS. The only reason we haven't seen it with Ebola is Ebola requires body fluid transfer and has a long incubation period. So it's a lot easier for us to manage. Ebola is also a virus, by the way. It's a viral hemorrhagic fever. There's a similar disease to Ebola called Marburg. You'll see some of that next week in the emerging infectious disease. But the whole point is some diseases are a lot more dangerous. The reason COVID's a lot more dangerous is, number one, the mortality rate's pretty high. Number two, it's airborne. Any infectious disease that's airborne is a lot more problematic in our ability to manage it and control it. Anyway, again, with HIV and with Ebola, both of those are bloodborne or body fluid borne and require an exchange of body fluids, in a lot of cases, an intimate exchange of body fluids before you can be exposed. But for an epidemic to get worldwide with it being a novel virus, meaning it's unusual, it's not one we've seen before, that's when we consider it pandemic. And the last pandemic we had was really 2009, but it was far less impactful than this. It was referred to as swine flu. It's a bit of a misnomer. There was some swine component, and it was an unusual version of H1N1, which is the common influenza virus we see each year, but it was an unusual strain that included, so all of the influenzas are found in fowl and in the avian population. And so, anything that flies, particularly in migratory birds, makes it easier for it to be spread. H1N1 and a number of other influenzas wind up moving that way, but the most common are H1N1 and today H3N2 is a little bit more common. Again, stuff that we'll talk about a little bit more next week, but as it moves worldwide and it's unusual and it's a novel virus, we call that a pandemic. The four types of infectious disease, I guess, what are things that can cause an infectious disease? A bacteria, a virus, a fungi, and a parasite. Just understand bacterial infections used to kill far more people than viral infections. In fact, the Black Death, the Black Plague of 1347 to 1351 killed as much as 60% of the entire population of the European continent. Pretty dramatic. Again, I've got just a couple of quick slides about that tonight. I've got a little bit more information about that next week. But bacteria and bacterial diseases used to be really the basis for what we considered the plague and other types of infectious disease. We didn't fully understand infectious disease 500 years ago, but the big difference in the last 75 years is the discovery of both penicillin and antibiotics in general. And because we have a variety of antibiotics, it's a lot easier for us to control bacterial infections and stop them long before they become either outbreaks or epidemics or pandemics. The virus, on the other hand, is a lot more challenging. It's smaller. It can move into a form of stasis for a while and then be reactivated. It can live for an extended period of time on different types of surfaces. It doesn't have its own nucleus. It requires a host to be able to spread. And viruses are a little bit tougher to detect. We also don't have a lot of antivirals. Our way of managing virus infections is through vaccinations. And that's gone really well. From time to time you read some of this, I don't want to call it nonsense, but generally it is nonsense about vaccines. There are some incremental components of vaccines that are there to prolong the shelf life of the vaccine. But vaccines are 99.999% effective and safe. And I recognize that, for every 999,000 people that are not affected, there may be a person or 10 people that have some type of an unusual outcome. But just, again, bear in mind, the only alternative to not using vaccines is something called herd immunity. And herd immunity requires exposing everyone and allowing, what's referred to as drawing a blank at the moment, survival of the fittest. The point is, if your body can withstand the virus and overcome it, then you'll be fine. And if not, well, you won't be fine. In fact, during World War I, there were different military bases where H1N1, the 1918 flu, was actually exposed to several units because they were young and healthy, and they were thought to be, they would recover quickly from the flu, and not all of them did. Some of them died. But those who did, their bodies built up antibodies to the flu, and so they were protected from the flu going forward, or that particular strain of flu going forward. That's called herd immunity. You can achieve herd immunity one of two ways. Number one, expose about 65 to 75% of the population to the virus, and everybody who recovers is their body develops antibodies, and they're typically safe, at least for some period of time. Because this is a coronavirus, we don't know how long that safe period is going to be, but I mean, that's certainly a strategy. Just understand, at the mortality rate that we've had, to reach herd immunity in the United States, we would have to be able to accept between 2 and 4 million deaths. If we're okay with that, again, that number is statistically important. If you're one of the deaths, it's not, it's not so important if you're not, I guess. I don't know. It just, herd immunity is not a safe approach. I don't think it's a safe approach. But we can achieve herd immunity in another way, and that's through a vaccination strategy. And that's really the bigger approach, and that's really the best way to go about things. That's how we've made measles almost obsolete, mumps, rubella, polio. There are so many diseases that were substantial and killed significant numbers of people 50 years ago, 75 years ago, that we've developed herd immunity today because of vaccines. But again, that's the best way to manage a virus. Fungi and parasites are much smaller subsets of infectious disease or communicable disease. They typically are not deadly. One exception would be, there was a fungus there were some patients in the San Francisco area in the 1980s that were dying of an unusual fungal infection, and they couldn't figure out why. And what they began to determine was it was affecting typically males who had same-sex partners, and so that was really the early identification of clusters of people who had HIV that was evolving into AIDS. And as the body's autoimmune system began to break down and begin to fail, they began dying of this fungal infection that otherwise would be rather benign. But because the body had lost its ability to produce antibodies and fight off the fungal infection, now suddenly they were seeing people dying of this fungal infection. The real culprit, though, was the virus. It was the human immunodeficiency virus that had led to AIDS. And so while they died from a fungal infection, the underlying contributing factor that put their body in a state that the body couldn't fight off the fungal infection was HIV. Infrastructure stability and responder to victim ratio, those things are important when we talk about disaster planning and disaster preparedness. We've got to be able to understand the sustainability, the finance of this, how much cash is on hand, what type of interruption insurance do you have, and then who has an interest in disaster planning. Quite honestly, if you work in a hospital, the Joint Commission has a huge interest in it, and the Centers for Medicare and Medicaid Services, they have standards associated with disaster planning and disaster operations. So there will be a part of your job that has to do with disaster management or disaster operations if you work in any type of organization that's either in the hospital or affiliated with the hospital. Okay, so let's look at a couple of slides. Let's see where we are time-wise. Okay, so I have about 18 minutes, 17 minutes before I need to wrap up. So a couple of things I want to be sure and talk about. Again, the types of disasters. We need to think an all hazards approach, because while we're not generally impacted by wildfire here in Louisiana, if you wind up living at some point in your life in California, yeah, it's a clear and present danger. A lot of areas west of at least the Rocky Mountain range has lower humidity, more prone to drought, and therefore more subject to wildfire. There's I think 24 active wildfires right now west of the Mississippi River. There's only one that's even close to the Mississippi, and that's in Oklahoma. Everything else is Colorado, Wyoming, Montana, Idaho, and then Washington, Oregon, and California. Typhoon is not something that we use here in the United States. The only technical parts of the United States that use the word typhoon, Guam, the Northern Marianas, but commonwealths or territories of the United States that are in the far west Pacific. The Pacific next to the United States, or the next to California over to Hawaii, those storms are called hurricanes. It's a hurricane, a typhoon, and a cyclone are really describing the same type of storm. The difference is hurricanes are more likely to be something that a term we use to describe something in the Atlantic or the Pacific close to North America. If we're talking about the Pacific close to the Asian continent, we're going to call it a typhoon. If it's the South Pacific or the Indian Ocean, we're more likely to call it a cyclone. Landslides, again, not really a problem that we have here. You need a lot of geography and topography. It's relatively flat here. We don't have a lot of mountain areas. And landslides actually are more prone to areas that are affected by wildfire. Tornadoes are something that impact our area, and certainly less to a lesser extent in southern Louisiana than in northern Louisiana, but the further you get away from the ocean, the more likely you are to see tornadoes, particularly in the Midwest portion of the United States. It's not that you don't see tornadoes in New Orleans, but they're a lot more likely to be less deadly, less impactful. Still can be dangerous, but not nearly as dangerous as some of what we see, again, more in the heartland of the United States. Let's kind of move on into, again, it's important because we want to preserve the operation, protect our staff, protect our employees, facility, and protect the financial health of our organization. It's also important for us to comply with standards. Again, the 4 phases that I mentioned earlier are stages of emergency management. The mitigation piece is that constant piece of looking for ways to avoid the disaster. But then planning for and preparing for disaster. When the event occurs, we respond to it. Once we've rescued the last person, that's when our recovery begins. We usually divide that up into a short-term and a long-term recovery. Short-term is basically getting the lights back on, getting the roads open. Long-term is if there's damage to infrastructure, repairing it and doing some long-term construction. And then all of this feeds back into the mitigation part of the cycle. Nothing there that we hadn't already talked about. Again, the HVA or the THIRA. HVA is more likely to be something that we discuss in the healthcare world. THIRA is more likely to be something that is used in the governmental world associated with disaster operation. Again, hazards not in your control. We can't control the hazard. We can control our vulnerability to the hazard. What are experiences we have? What are things we can do? How do we manage it? How do we prepare for it? And then from an academic standpoint, you know, there are things that we can do in terms of modeling and helping our friends in both the healthcare world and the disaster world plan for, prepare for, and in some cases respond to disaster. Let me give you just some examples. I like to use Hurricane Katrina. I was a responder in Hurricane Katrina, but this is where I responded, Hancock Regional Medical Center over in Bay St. Louis. Actually, I never made it to New Orleans. I was an administrator for a field hospital, and just a couple of, let's see. This is the hospital the reason I like to show this is you see where they built the hospital. So they built the hospital what really is more than a mile away from the ocean. Hurricane Camille came through in 1968, and really the only dry spot in this part of the community was this elevated area, and that's where they felt like would be safe to build their hospital. And if you don't know anything about Camille, occurred in 1968, just a catastrophic storm. Before Hurricane Katrina, Camille was really the storm that a lot of people compared to as the storm of all storms. And so this is what it looked like as the storm approached. And as the storm surge pushes water out of, the best way to think about storm surge is take a cup of water and blow across the top of it. If the cup of water is normally, if the water's not pouring out of the side of the cup, that's fine. But what happens when you blow across the top of the water? It starts to push it out the opposite side, okay? The same thing happens with a hurricane. Think of this enormous storm that's constantly blowing across the top of the ocean and constantly pushing water in front of the storm. And that's what very large storms are capable of doing. And when they talk about storm surge, the rainfall is somewhat of an impact, but it's far more likely to be storm surge, which is the wind pushing across the top of the water and then pushing that ocean water inland. again, I go back to if we look here, so here's where the hospital is. Well, within, within 8 hours of the storm coming ashore, you can see the water completely has surrounded the hospital and then continues to surround the hospital and flood the cars in the parking lot and then flood the hospital. You can see the water on the windows here as the water's again flooding the hospital at this point. And then that's the nurses' station. By this point, they've evacuated all of the patients and all of the employees up to the second floor of the hospital. And I like to show this picture just simply because this was where their generator was located. This was where their emergency power was located. And there's no roof on that building because it's been blown off. And this is one of the hospital rooms. And you can see, actually, you can see the water line of where the water's receding out of the hospital at that point. And this is what the medical records look like. When you talk about an electronic health record, the importance of it, I actually have another picture of many of these paper records laying out in the parking lot where they were letting them dry out. Not exactly HIPAA compliant, I guess would be the polite way of saying. That's proof of life. That just proves that I was there at the time. But I was the hospital administrator for this hospital, and we operated a field hospital there for about 2 months. We saw about 21,000 patients, but it's a large series of tents with a number of nurses, physicians, really people from around the state that we use to set up and operate our field hospital. And so the message that we heard from that was everyone needs to evacuate. And along came Hurricane Rita. And so, again, we saw evacuation, people lined up, they put them on buses. And then one of the buses caught fire and killed 23 people on board the bus. And so what it reminds us of is it is important to evacuate, but you also have to recognize who you're evacuating. If you're putting them, let's go back to this, if you're putting them with oxygen tanks in a typical civilian bus, you're not accounting for the fact that oxygen can create an environment that any spark can cause a fire. The air we breathe is about 21% oxygen. Well, if I have a lot of oxygen escaping because I'm treating a lot of people with oxygen in a closed-in facility like a bus, I may suddenly increase the parts per million of oxygen from a 21% to maybe 35, 40%, making it far more likely that a spark can lead to a fire and become catastrophic, such as this. And earthquakes, again, earthquakes aren't things that we see in Louisiana, but this is actually, there was actually 3 buildings here. This was a VA hospital. This building, and this building. This one completely collapsed, killing 49 people in the building. This was another hospital that was also impacted by the earthquake. Not a good place to park your ambulance. A little bit more look at what happened to the building, the Northridge earthquake. And then let's talk just briefly about tornadoes. This is the Joplin, Missouri tornado that struck the hospital there. Although only 4 people were killed in the hospital, it's important to recognize. So one other thing about this picture, so you see this firefighter standing here in the window. You see these white spaces. Do you know what the white spaces are? It's where you can see through the building. Okay, that's the sky on the other side of the building. Yeah, if we go back to, If we go back to, let's see if I've got another picture of the building. I'll show you the building's not that wide. And so as you look through the white spaces, what you're actually seeing is the sky on the other side of the building. There it is. So it's basically 3 rooms wide, 4 rooms wide. It's not a very wide part of the building, but again, it blew windows out on both sides and drywall out in the middle, making it something you could see all the way through. That's why they had to evacuate their building. Most of the people in the building were alive and were not seriously injured, but suddenly the 115 patients that were in the building had to be moved to the other hospital. Fortunately, there was another hospital in town, but now the other hospital is seeing all of the patients, and they've got to absorb all of the patients coming from this hospital. And this is just another image of what the hospital looked like before and after the wind damage. And the single biggest threat to man's continued dominance of the planet is the virus. We've probably seen that more so in the last 7 months than probably in the last 20 years. But it does remind us that a virus can lead to a truly catastrophic situation. The 1918 flu influenza was killed between 5 to 20% of the world population. We certainly don't think we're going to end up anywhere near that with SARS-CoV-2, also known as COVID-19. But it will be substantial. There will be significant loss of life. We've already had more than 1 million people to die in the first 7 months of COVID-19, and now with a world population of about 7 billion, that's not a substantial number of people. But again, in terms of comparing it to anything else in the United States, it will be the 3rd leading cause of death this year, behind cancer and heart disease. So it's not the leading cause of death, but it's certainly a scary situation. This is the doctor and plague gear from the 1347 to 1351 Black Plague of Europe. Again, this is what PPE looked like 700 years ago. Okay, goggles, a hat, a cape, a wand to direct a patient, and a mask. And the elongated mask was built to put filters in it. So I don't know that I necessarily want an elongated mask to put a filter in, but I don't know that they were quite as far off as maybe we thought they were at one point. This is what the 1918 flu pandemic looked like, which is an interesting picture compared to something else I'll show you in just a few minutes. This is stuff that we'll see more of next week, so I don't want to spend too much time on it here. One thing I do want to show you quickly about fire: the threat of fire is really that common threat that we all share. This is a station nightclub fire in Rhode Island, and the station nightclub fire, so you had a dance floor here. You had roughly about 350 people that were attending. The band was on the stage here, and so they recreated the fire to try and understand how quickly it became a disaster. And so this is at 0 seconds. They ignite the fire. 10 seconds, 20 seconds, 30 seconds, 40 seconds, 50 seconds, 60 seconds, 70 seconds. At 80 seconds, it's almost so thick you can't see to find your way out. Now you're in a building with 350 people, and there are 5 exits, one of which is blocked by the fire. So how, and most of the people, or many of the people in this at this activity are probably consuming adult beverages, and and probably not immediately thinking, oh, there's a fire, I need to leave now. And so even by the time they did get to the point where they decided there's a fire, I need to leave now. So this is at 80 seconds. Let's also look at the temperature as flashover occurs. At 85 seconds, flashover begins to occur. If we look at our temperature, this is in Celsius. So this is about 1500 degrees Fahrenheit. Obviously, this is not, sustainable for life as we know it. By 90 seconds, we have a complete blackout situation, and we have a complete flashover, and there is absolutely no way anyone can be alive in this part of the building anymore. So from the moment the very first flame was seen until it was completely unlivable was 90 seconds. And I just described a scenario that could exist in New Orleans, pick your state, pick your city. And the point is, the threat of fire is the clear and present danger that really doesn't matter whether you're in California or Louisiana or New York or North Carolina or Florida. And this is where the deaths were. And quite all right, I understand. And so let's kind of wrap up with just a couple of things. Again, just understand surge capacity and surge planning, the importance of it. We really look at it into three pieces of staff, space, and stuff, or supplies. And then a critical solution for every disaster is, how do you create surge? This was our surge hospital in New Orleans. We actually still have part of that up, but this is, at one point we could have managed up to 2,000 patients in this hospital in the convention center. This was a surge hospital that they built in Wuhan, China. They actually built 2 of those in a period of about 2 months. But the whole point is, how do you create space that can manage significant numbers of patients? Where do you get the equipment? Where do you get the people from? And I think that's pretty much it. So let me wrap up with this. First of all, are there any questions? Okay. And then let me just say, if there's anything that you need going on, or if you have a question about something, please let me know. Again, the only thing that I still have outstanding in grading is the discussion forums, but I'm trying to get them caught up. My aim is to have them caught up by this weekend. And I think at that point, I've got everything caught up and everything graded. But if you've got something out there that you've got a question about, or something that you missed that you want to find out more about, just send me an email. Things are a little bit more calm in my life at the moment, aside from the hurricane we have going on tomorrow. But it'll be through here, and hopefully not a big problem in the next day or so. But if you need anything, please let me know. Okay.
I have a quick
Yes.
question. As far as with all of the quizzes that we have taken, and I've noticed that, that we always end up having some of the same questions on the other tests. And probably, I'm thinking that at the end, we're probably going to get some of those other questions thrown in at the very end. So my question is, can we know what questions we got wrong, what the answers were supposed to be? Or will that just be something that we just need to refer back to our
So that's a good question. What I normally do is I normally program the quiz to where, once the quiz is closed and no one else is taking that quiz, and the quiz is considered locked at that point, you should be able to go back in and then look at your quiz and see what you got right and what you got wrong. If you can't do that while other people may be taking the quiz, but there is, you should be able to look at it. Most of the quizzes that are closed now and locked now, you should be able to look back on and see what you got right or what you got wrong.
Okay.
Yeah, is that helpful? Okay.
Yes, it is. Thank you.
Okay. Okay, I will tell you this. Each of those quizzes require a specific setting for you to be able to do that. And I think I've selected that setting on all of the quizzes, but there's 1,000 moving pieces in Moodle. And for me to be sure I've done it, I can't tell you I've done it on all of them. I can't tell you with absolute certainty I've done it on all of them. So if you find one that's not working right, please let me know, and I'll go back in and check the setting on it for you. Okay?
Okay, thank you.
Sure, sure. Any other questions from anyone?
For next week, are we going to have our class on Zoom?
I'm sorry?
For next week, are we going to have class on the 3rd?
Yes.
Okay, I was curious because I think I saw a note that we weren't going to have it because of Election Day.
Oh, that's a good question. That is a good question. We were told not to have class on Election Day. What I will do, instead of having class, because that is supposed to be a holiday, I'll pre-record this same thing so that you can go back and look at it. Well,
Okay.
Is that okay?
Yes, sounds good.
Okay. Thanks for bringing that up. I had completely forgotten about it. You're exactly right. Okay, I don't have anything else. So next Tuesday, I won't see you at this time, but I'll pre-record something so that you can see it on Zoom. If you have any questions, please let me know. But until that time, I'll see you.
Okay, thank you.
And stay safe tomorrow.
Thank
You too.